Hi, everyone. This is Nasir Gami. Thanks for joining me again at the live stream podcast that we've been doing recently. I have Daniel Herringer with me, a psychiatry resident and friend of mine who's been helping me organize and run these series. And he'll be asking some questions or engaging in a discussion with me soon after we get started. Hi, Daniel. Thanks for joining us.
It's my pleasure and honor. I'll step back and ask some questions later.
All right, thanks a lot, Daniel. So the topic today is about comorbidities and the idea that comorbidities really are not really comorbidities, or it's not a correct or valid concept often, and that instead the way to understand this is the concept of a diagnostic hierarchy. So let me explain what I think about this, and then we'll have some discussion. So in general, in particular in medicine, the concept of comorbidity, the actual word, and the idea was created in the late 1960s. And the idea was that you have two different kinds of diseases that are unrelated to each other, but happen at the same time. So for instance, you might have asthma, and you might also have, basal cell carcinoma of your skin, or you might have epilepsy. These are different things. You have asthma and epilepsy. They're comorbidities. They're two different diseases that happen at the same time, but they don't cause each other. They're not happening because they're related to each other. But if you happen to have two diseases, they can have consequences that might affect the other one. So for instance, if you have asthma and you have hypoxia, maybe you'll be more likely to have a seizure. But you have seizures anyway. It's not because of the asthma. So that's the original idea of comorbidity, two independent diseases happening simultaneously. Now, that was in 1969, and epidemiologist Alvin Feinstein wrote about that. Then in 1980, when the third edition of DSM came out, DSM-3, the term comorbidity began to be used for definitions of quote-unquote disorders which are not valid diseases to begin with, as we've discussed before, and with overlapping symptoms. So for instance, generalized anxiety disorder was created falsely with no validity, with half the criteria being the same definitions as the criteria for depression. So if you meet generalized anxiety disorder criteria, GAD, you also are likely to meet major depressive disorder criteria, MDD, because you automatically meet half criteria when you have one with the other. And then people say, oh my gosh, there's this terrible comorbidity problem, MDD and GAD happening together. It's a terrible thing. Well, you've defined it that way. These are not two independent diseases happening simultaneously by chance. It's two non-diseases, two invalid constructs defined in such a way that they overlap in half their symptoms. So it's not truly comorbidity at all. Another way of understanding this is that nature and God, if you want to think of it that way, are not so cruel that they constantly give people two or three diseases at a time. Nature usually hands out diseases one at a time. You get one. After a while, some years later, maybe you get unlucky, you have another one. But it's not constantly giving you two or three at a time. So, these ridiculously high numbers of 50, 60, 70% so-called mental illness comorbidity using DSM definitions is unnatural, unscientific, and doesn't actually happen in the real world. So the idea just isn't correct. How should we understand this differently? When you are in medical training, we often learn that the beginning of the process of making a diagnosis of somebody is a differential diagnosis. The patient presents to you with a constellation of symptoms and signs. You don't just say, okay, it's diagnosis A, B, and C, and they have these three comorbidities where the symptoms overlap. No, what you do instead is you make a differential diagnosis of the various possibilities, and then you rule out the ones at the top as you go down to the bottom. And how do you set that up? Well, there's a couple ways. One is if you know the causes and the etiologies, you put those at the top, and then you assess whether those causes are present, and then you rule it out. For instance, infections, you could do a blood test to see if somebody has positive results on some bacteria. Now, a lot of people in psychiatry say, well, we can't do it that way because we don't know the etiologies or causes. Well, that's also a minority of cases in medicine. And we don't know the cause of migraine, of epilepsy, of lupus, of lots of things, but we can diagnose them nonetheless. And so the other way of addressing differential diagnosis is to put the illnesses that have lots of symptoms at the top and rule them out before you go further and further down to more narrow diagnoses. So for instance, if someone comes to you with fever, chills, and night sweats, you don't say automatically, oh, it's just a viral infection. You rule out HIV, which can cause infection. You rule out syphilis. These are obvious things. You rule out various other possibilities. So the possibility then is that what you really need to be doing is ruling out diagnoses with multiple symptoms before you diagnose them with just one symptom. So I hope you're hearing me okay. I'm getting a little feedback that maybe the volume isn't and audio isn't coming through well. Do have a chat if there's any problems with that. Let me know, and I can adjust what I'm doing with the volume. Otherwise, I'm going to go ahead and just show you this one slide. This is the only slide I'm going to show you today. How do you apply this hierarchy, this differential diagnosis concept to psychiatry? And my idea is that you do it with this concept of a hierarchy of diagnosis. I got a YouTube comment that you can hear me fine. Thank you. So the concept of a hierarchy is the same as the concept of a differential diagnosis. It's saying we have to rule out some things before we diagnose others. And we're going to do it by the concept of ruling out diagnoses that have the most symptoms before we diagnose conditions with fewer symptoms. So this is an old paper from 1979 that I've kind of adapted for my purposes, which thinks through the idea of what kinds of diagnoses in psychiatry have more symptoms versus less. And as you can see, mood illnesses can present with all the psychopathology that you can think of, any kind of symptoms. You not only have mood symptoms like depression or mania, but you can have psychosis, delusions, hallucinations. You can have anxiety. You can have changes in your personality. You can have executive function impairment and cognitive impairment. So every time you have bipolar illness, you don't also have schizophrenia, GAD, borderline personality, and ADD, which is the way the DSM comorbidity system sets it up. You just have bipolar illness. And the way you know is that when you treat the bipolar illness and the symptoms of the mood illness go away, all the other symptoms get better too. The psychosis goes away, the anxiety gets better, the focus gets better, and the personality goes back to the baseline. Similarly, if you have schizophrenia, you can have anxiety, you can have personality changes, you can have executive function. Just because you have schizophrenia doesn't mean you always also have GAD, personality disorders, and ADD. Also, you can have anxiety conditions and not have schizophrenia or mood illness, and the anxiety itself causes executive function. You don't just have GAD and ADD all the time together. When you have personality disorders or ADD, these should be diagnoses that are made, if they're valid at all, which many of them are not. But if they are valid, they should be made in the absence of mood illnesses, psychotic illnesses, or other conditions that can cause them. And instead, people will diagnose the ADD and borderline personality all the time, and then they throw on top of it, oh, there's also comorbid GAD, MDD, even bipolar. And I think that's the opposite of the way we should be thinking about this. That's starting from the bottom of the hierarchy as opposed to the top. So if you take this approach to a diagnostic hierarchy, you'll make fewer diagnoses. You'll treat the causes, which is the actual illness, not the symptoms. And the patient's symptoms will get better with fewer treatments because you're treating the causes and not the effects. So it makes you engage in less polydiagnosis and also less polypharmacy with fewer treatments, better outcomes, more efficacy, and less side effects. And we can discuss, the details of how you think about the specific hierarchy I presented here in our discussion, but that's the general idea. So I'm going to shift off the screen from the slide and invite Daniel to join me and maybe start having a discussion about some of this. And if you have questions, please put them in the app. I have one comment that the H in ADHD should be deleted. There's no hyperactivity. Yes, that's true. We've talked about that a little before. That hasn't been proven to be a legitimate part of ADD. So I'll just throw that out there. But Daniel, let me pass it over to you.
Oh, Well, thanks for bringing me here, and I'll try to keep it casual and conversational. But the way when you present those ideas, it feels like very clear cut, right? It feels like super obvious. Yes, it makes super sense. But in reality, it does seem like our patients, they come up with a whole bunch of different groups of presentations. And so you have the depressed patient, but then you have the depressed and anxious patient. Doesn't it make sense to have a different characterization or a different name for this different presentation as well? And what would be the alternative to like having this two conditions as comorbidities?
Well, I mean, the alternative is to have valid diagnoses. So they took out neurotic depression in DSM-3 because they didn't want to use the word neurotic. And then they created GAD out of the blue, which had no validity to it at all. They just made it up. And then they invented dysthymia as well, misusing the idea, just so that they could replace the diagnosis of neurotic depression with diagnoses that psychoanalysts could use to get insurance reimbursement for psychoanalytic psychotherapy in 1980. So they gave them MDD, GAD, and dysthymia, making up these definitions out of nothing and getting rid of actually a reasonably well scientifically validated concept of neurotic depression, which means some people have anxiety and depression together all the time. It's mild, it's chronic, it's not episodic, it's not genetic, different than manic depressive illness. So if you have that concept, then when they have anxiety and depression, but they have the chronicity of it and the mildness of it and the lack of family history, these other diagnostic validators, then you diagnose neurotic depression. You don't need to just focus on the symptoms and say, let's treat two different disorders, quote unquote, for the symptoms. This is part of the whole invalidity of DSM, that it only looks at symptoms right now, and it completely ignores the other diagnostic validators, namely the course of the illness and the family history.
I see. But the other thing that jumped to my mind when I was hearing you talk is how when we have, like in the rest of medicine, we have patients who have obesity, they have high blood pressure, they have high cholesterol, they have a whole bunch of it's a bunch of diagnoses. They're not detached. So in my mind, it makes sense that when you have someone with a messed up upbringing, I'm making use of bad language, but when you have a lot of issues happening to the same person, it makes sense to have a lot of diagnoses later as well, such as having a bad diet and bad exercise routine can also be correlated to having high blood pressure, high cholesterol, and having multiple diagnoses.
Yeah, that's a good point. So if you use the hypertension and high cholesterol analogy, those are different things, but they have similar consequences. So high cholesterol causes heart attacks, and hypertension can also cause heart attacks, but also strokes. Cholesterol can also lead to strokes. Those aren't actually diseases. Those are risk factors for diseases. The disease is actually having the stroke or heart attack. So one way of understanding that is it's more about pathophysiology or pathogenesis. And underlying both hypertension and high blood pressure is inflammation. So you might even find a common pathogenesis for both of those. But if someone has, say, childhood trauma and lots of other problems, and poverty and violence, and let's say they also happen to get the genetics for bipolar disease, which is a completely genetic disease, yes, they might have a true comorbidity of PTSD and bipolar disease 30 years later. My point is that a lot of people don't have any of that, and they're still being labeled comorbid 50 to 75% of the time just because of overlap with DSM symptoms, which have never been validated to begin with in the majority of cases, and that's a pseudo problem. The problem is not really that these people have comorbidities in terms of independent, valid diseases. It's just a DSM problem of a false concept with a lot of overlap, and it's leading people to make unnecessary diagnosis and multiple treatments, which actually are hurting people, not helping them. So my point is not that there's never comorbidity, to your question. My point is it's much, much less than we claim. I would say true comorbidity of random occurrence of two psychiatric problems, often PTSD or a disease or maybe personality disorder and some other disease. Unfortunately, in the same person, that might happen in 10 to 20% of people with psychiatric diagnoses at the most, who are very unfortunate. But it does not happen in the majority, 75% of people. No, not at all.
Well, I do find it easy to agree that we have an exaggerated, unlikely when compared to the rest of medicine, an unlikely amount of comorbidity. But at the same time, for me, it's easy to imagine that, for example, someone who has a mood illness has a different kind of energy inside of them, a different way of thinking, a different way of feeling, a different way of experiencing the world. That should certainly impact personality and how they interact with other people, for example.
It does
So
impact
it doesn't sound
personality.
like distant to have
No,
those
it's
as
true. It does
comorbidities. This
impact.
is what I'm saying.
It does impact personality, but that doesn't mean they have a personality disorder, quote unquote, comorbidity, because the whole concept of personality disorders is false. I'm happy to talk about personality, but not personality, quote unquote, disorders. Maybe that's another podcast episode. Dan.
Yeah, I mean, I think if we open that up, that can be like a huge conversation. It's hard. I'm trying to find the words and the vocabulary to be on the same page when you talk about these things. It feels like it's hard to find the words and share these concepts, as a lot of what we talk DSM talk, right? This is all we learn.
Mm-hmm.
And it's hard to talk psychiatry without the words to talk about it. And when you say all that, then it gets kind of hard. But then,
yeah, no, it's possible though, Daniel. I think that's an important point. Reminds me of George Orwell, who said that your language constrains your thought. So if we keep using DSM terms, it's very hard not to think DSM-like, including these false concepts of comorbidity. So we need to stop using DSM terms. And there's a way to do that. I do that. I speak about psychiatric diagnoses without ever using the word disorder, quote unquote, which is a false DSM concept. And I don't use DSM terms like MDD, GAD, etc. I use other words like manic depressive illness, like depressive states, mixed states, anxiety states, not anxiety disorder, personality, not personality disorder. So there's ways to talk without using the DSM phrases, which constrain our thinking.
fair enough. I think, so let's bring it more to practice then. I think one of the comments, Larry commented about this is a common topic, I believe, the borderline manic depressive, cyclothymia, and the combo. I'm just adding to the combo, which is very common in the daily practice, the PTSD, ADD kind of situation. So in reality, it's very reasonable to imagine a situation when there is manic depressive illness, genetics involved, and a patient with early childhood trauma, sexual trauma in a female, later on presenting with all of those typical symptoms that are very classic of borderline personality disorder. And I think we've talked about this before, and borderline personality disorder is one of the few personality disorders that are kind of like more validated or somewhat consistent in the literature, like with antisocial.
Yep, though not using DSM criteria, but go ahead.
So yeah, that makes it. So what I'm trying to make it more concrete, how to think about it in a more concrete manner. Can we? So it's hard to attribute everything in this presentation to just manic depressive illness, especially when we see that they do not respond as well to the medications that we give them as other manic depressive illness patients that do not meet all of those criteria for borderline personality disorder, for example.
Yeah. Well, let me speak to that, and I also could use another example, the bipolar OCD comorbidity, for instance. Let me say borderline personality. Let's start with that. There was an old study once looking at people with borderline personality who, quote unquote, also had MDD comorbidity, quote unquote MDD comorbidity. That is, they had a full-blown depressive episode and they had borderline personality diagnosis. They treated the depression and followed them for about 6 to 12 months. and half of the borderline personality went away. Cured it. They didn't have it anymore. Let me give you another example. It just happened this week. A few days ago, one of my patients said, you stopped my Lexapro and my ADD went away. You stopped my Lexapro and my ADD went away. So Daniel, you're a young resident. I'm put you on the spot. How would you interpret that? If someone says, you stopped my Lexapro and my ADD went away.
They never had any ADD to begin with. That was the side effect of the medication, likely.
In what way? Why would they think they had ADD if it was caused by Lexapro?
The way I'm thinking, it's kind of like I use the heuristics of energy or internal energy. So they had increased internal mental energy and had raised.
So what do we call that in psychopathology when your energy is high?
Well,
what do we call it when your energy is low?
We call it manic-like activity. That's what I'm thinking.
Well, you don't need to say like, it's mania. It's manic. And so mania means psychomotor excitation. That's the classic psychopathology definition. You're sped up in your movement, thinking, and feelings. And depression means psychomotor retardation. You're slowed down in your thinking, movement, and feelings. That's the way it's been defined for 2,000 years. Forget how DSM has been talking about it for 40 years. So she was on Lexapro, and she was in a mixed state. She was depressed and psychomotor, excited, agitated. And of course, she couldn't focus when she's in a mixed state of depression and mania happening at the same time. And that was being labeled ADD. Oh, poor lady. She has MDD and ADD. That's why she needs the Lexapro, and some other people would give her Adderall. What I do is I say, no, she doesn't have MDD or ADD. She has a mixed state. She's getting misdiagnosed with these DSM concepts. Let me stop the antidepressants, which were proven to cause mixed states. And her manic symptoms got better. Her depression persists. So we've converted her mixed state to more of a pure depression. But because the manic side is gone, she's more able to focus and concentrate, and she's less angry. And that's where the so-called ADD went away. So that's kind of a tongue-in-cheek way of saying, you stopped my Lexapro, my ADD went away, is really a way of applying the concept of a diagnostic hierarchy. I'm not saying, let me take each symptom and label them with a disorder and treat that, ADD, MDD, GAD. I'm saying, let me understand what the psychopathology here is. At the top of the hierarchy, manic depressive illness, mixed state, most common presentation, causes both anxiety and executive dysfunction and inattention. Let me handle that first and see what's left over. And now I see there's depression left over, so we still got to manage that. But the ADD is gone. She never had that to begin with. So that's a clinical example of how you can manage this. Let me give you a little bit of literature example. Use the bipolar OCD comorbidity idea. We did a meta-analysis some years ago where we looked at all the studies done on the bipolar OCD comorbidity. And some of the studies assessed the OCD during and after the manic or depressive episodes. And what we found is that in about half the cases, the OCD went away after the manic or depressive episodes, when there was no longer depression or mania actively present. So half the patients with supposed bipolar OCD comorbidity don't actually have it. The OCD is just a symptom of the mood state, the manic or depressive state, which happens a lot. And so generally it's said that the comorbidity is 20% using DSM definitions. It's really 10% because you got to take out that 50, that half that is not a real comorbidity. So that's another way of understanding this. I'm not saying the comorbidities never happen. I'm saying they're half as frequent as we say they are, or maybe even less.
When I try to apply this thought into practice, it does really feel like, so we have a disease that's very prevalent and that presents itself in a multitude of ways. So we have manic depressive illness that can present itself in some patients with more executive dysfunction, in some patients with more irritability and dysphoric energy, for example. And in other patients, we have more of the depressive presentation, and the temporality of the presentation can also be varied. This is what I'm getting from this. We have one big diagnosis that can present itself in a multitude of, like lupus or something.
Exactly. Lupus, syphilis, HIV. Think of all those things as analogies to manic depressive illness. You know, there's the famous saying in medicine that syphilis is the what was the phrase they used? The great pretender. because it can produce any symptom, and it can pretend to be any illness. You can think of manic depressive illness that way for psychiatry. It needs to be ruled out in every person because it can produce any symptom. Sometimes it's easily able to be ruled out, but still needs to be assessed. One quick thing to say about that: sometimes people, again, remember, manic depressive illness is not the same thing as bipolar disorder. It means bipolar illness plus unipolar depression. It means mood episodes of any kind that are recurrent, not just the manic ones. They do have to be episodes. That means they're not just mild symptoms. However, there's the spectrum of manic depressive illness where you have the mild mood temperaments, like cyclothymia, up and down all the time, hyperthymia, always a little manic, and dysthymia, always a little depressed. So since that's all the time, manic depressive illness does not have to be seen only as an episodic condition if you take into account mood temperaments. And so we have a comment on the chat from someone who says, what about the apparent chronicity of ADD? Was the patient in a mixed state since childhood, or was the ADD episodic? Again, we need to have a separate talk about ADD again, or you can go look at my podcast on ADD. The concept's completely invalid because the adults who meet the definition didn't have it in childhood, and the children who meet the definition don't have it in adulthood. I'm not making this up. 2 large prospective studies show this. So it doesn't matter whether she had it in childhood or not because it's not a legitimate concept. But even if she did, you could have mood temperaments like dysthymia, cyclothymia, hyperthymia since childhood. That's the way it works. And so that chronicity of the executive function does not mean it's ADD. It could still be cyclothymia or hyperthymia, which is part of the manic depressive spectrum. One other larger comment on this, another chat comment, how can the diagnostic hierarchy be reintroduced without necessarily implying a Kraepelinian style rebiologization of complex and subjectively mediated conditions? If I can talk to that, Daniel, for a minute.
That's amazing. A great question. Honestly.
It's a good question. The Kraepelinian perspective was biological. I'm not saying we should turn the clock back to 1898 and think exactly like Kraepelin did. I think we should, like with anything, I never read a book actually where I agree with 100% of it. I never read anything that I agree with 100%. Brilliant people like Kraepelin, I might agree with 1/2 of what they say, or 2/3 of what they say, or maybe it's just not a matter of my agreement. That might be proven true, 1/2 or 2/3 of what they say, and the other 1/2 isn't. So we don't have to be completely biological like Kraepelin was about everything. But I think it is reasonable to say that the Kraepelinian concept of manic depressive illness and dementia precox, schizophrenia, defined the way he did, has been proven to be completely biological and completely genetic. It doesn't matter that the symptoms are subjective. You hear voices, you feel sad. Well, I know you can hear voices and feel sad in a seizure, and that's a completely biological state. The fact that you have subjective symptoms doesn't mean you might not have an objective biological cause for it. But that also doesn't mean that every other diagnosis is seen as biological. I'm not saying PTSD is biological. It's completely environmental by definition. I'm not saying that that neurotic depression is biological, or a range of other things. But some things are biological and diseases, as Kraepelin said, and some things aren't. So accepting those Kraepelinian diagnoses doesn't mean we have to go into an extremist, doesn't imply that we have to be extremist in a biological sense. Just my comments on that. We're getting in at 28 minutes, Daniel, and probably 30 minutes is a good amount of time for the podcast. We got a lot of chat questions and comments, so I appreciate. But let me turn it back to you, Daniel, see if you want to try to talk a little more and to tie things up.
I think we could turn to wrap things up. But one thing that comes to my mind, and that would to this comment about the Kraepelinian and more biological approach to things, is it's reasonable to understand that the biology interacts with the social as well. As I was saying before, it's easy for me to imagine a situation where mood disorders impact how people relate to each other and how these relationships shape their personalities. And so we have biological and social kind of being interpreted in a different way than we commonly see in some books. And I don't think it's extreme at all. I don't think we necessarily go that way. And being plural in the way we see psychiatry, I think that's the best way to move forward and have the best conclusions for this.
Well, let me just say, Daniel, just to express myself on that a little more. I don't think being plural is actually the issue, or mono. I think it's just being scientifically valid. If it turns out that some disease is 100% biological, we should accept that. If it turns out it's 100% environmental, we should accept that. If it turns out it's 50-50, we should accept that. We shouldn't impose our own wishes that things should be quote unquote biopsychosocial or equally both or whatever. And furthermore, even if they are relevant, they're not equally relevant. So for instance, if you take a disease like manic depressive illness, it's completely biological and genetic in its etiology, almost 100%. If you don't believe that, we can talk about that more differently in a different setting, but it's been proven in twin studies, meta-analyses. But that means that the concept of the illness is not that you will have manic and depressive episodes all the time. It's that you're biologically susceptible to having manic and depressive episodes with triggers. The triggers are social triggers often. Sometimes they're biological triggers like medication, and antidepressants cause mania. But it could be social triggers like a job loss causing depression. Yes, the job loss is relevant. That person goes into a full-blown depressive episode. But only 2 to 5% of people experience that recurrently throughout their lives with these triggers because they have the biology of manic depressive illness. The other 95% of the world also loses their jobs, but they don't go into clinical depressive episodes. So yeah, there's a social factor, but it's secondary and less important than the biology in the case of a disease like manic depression. It's not all or nothing, but it's also not equal.
Perfect. Yeah, I think I'm just trying to explore with the limited language that I'm accumulating over time, but with the limited vocabulary, kind of like an explorative and inductive way of thinking, trying to predict what's actually going to be real and valid. But great conversation. Thank you so much, everyone, for the comments. I'm sorry we didn't have the time for all of the questions. They were all great, but we'll keep writing them down, and we should address them in the future.
Yes, thank you. We got great comments this week, and I'll put, as usual, I'll after the conversation, when I see what we've talked about, I'll put up some links to some articles on the chat so you can do some further reading. Thank you all for joining us today.
Bye-bye.
Bye.